So welcome to this session on trials and tribulations. And as I often say, it's not the quantity that counts, but the quality. So given the quantity, I think we have a high quality person here.
No, very, very high quality. Yeah. Is how many minutes we have?
We have 30 minutes for each talk. We're supposed to have 3 talks.
So we have 1.5 hours.
I think we'll be done.
Huh? We'll be quicker than that. We will be quicker. But so you present very fast because I think everybody knows the trial.
Yeah.
So then we discuss.
Okay.
Because I think discussion is very important, right?
Absolutely.
You agree? Yeah, I'm sure you will do that.
So I'm presenting early TAVR, and these are my disclosure. So as you know, timing is everything. If we intervene too early in the course of the disease, we expose the patient to the unnecessary risk of the complication itself and the procedure itself and the complication of the prosthetic valve. And if we intervene too late, there is, of course, the risk of irreversible cardiac damage, myocardial fibrosis, and sequelae. So if we look in the guidelines for the patients with asymptomatic severe AS at the present time, there is no class 1 indication except if the patient has an indication for another cardiac surgery or a reduced EF. Otherwise, there are still some openings, and that we use a lot. Class 2As, so if the patient has very severe AS, markedly elevated BNP, fast stenosis progression. Okay. So the dilemma that we have had for many years in this asymptomatic patient with severe AS, should we do an early prophylactic AVR versus a watchful waiting, wait for symptoms or LVEF to decline? And I have the perception that even before doing these trials, we were trying to find excuse to intervene on these patients. So this is the early TAVR trial. You know the design. Asymptomatic severe AS, age 65 years old or more, STS score less than 10%, preserved EF. They were put on a treadmill to make sure they are true asymptomatic. And they are randomized to transfemoral TAVR with a SAPIEN 3 platform or clinical surveillance. The primary endpoint with a superiority hypothesis is a composite of all-cause mortality, any stroke, or unplanned cardiovascular hospitalization, not heart failure hospitalization, unplanned cardiovascular hospitalization at 2 years. Okay, this is the primary endpoint. There is no surprise here because you already know the results.
We only have a few of us here. I'm going to ask a question while we go. Okay. Go back to the next slide. Go back.
I go back, okay. Well, yeah, that's good.
Right there.
I like it, yeah.
So what's the difference between this trial and recovery for AVR, really?
For AVR...
the recovery trial.
The recovery trial is the first trial that has been done in asymptomatic...
No, this is the recovery is a surgical trial.
It's a surgical.
So this is a TAVI trial, recovery is a surgical trial.
This one is a TAVR only.
Yeah. Do you think there's going to be any difference?
No, but the difference is that, so in the recovery, number 1 is very small.
Yeah.
So this is a 1,000-patient trial. And the second is
you don't need 1,000 patients, probably.
No, but we do, because you see it. But the question is that the negative treadmill test was a little bit unique. Because in the recovery trial, they did not do a stress test to enroll. But now negative is a question mark, that how do you confirm negative? Because when you put a patient on a treadmill, what is considered negative? That they're truly asymptomatic, meaning even if I go on a treadmill, at 11 minutes, I'm short of breath. So whether this is considered symptomatic or asymptomatic?
No, that's a good point.
So, and severe, so this is asymptomatic severe AS. So severe is classically...
High graded.
Yeah.
40 or more than 4 meters per second.
Yeah.
And that's the difference with recovery.
This is recovery trial. 4.5.
Recovery was very severe.
4.5.
Peak jet velocity more than 5.
No, 4.5.
4.5.
Recovery?
4.5.
4.5, yeah, maybe. Okay, that's okay. Good.
Okay, it's very similar in a way that it is severe, yeah. But the question is that what do you consider?
I don't even think there's equipoise here, but go ahead.
And so this is the primary endpoint, okay? So at 2 years, 37.5% of the composite versus in early TAVR, 17.7.
So just like recovery?
Yeah, but with different endpoint. Recovery was mortality. We're talking about the composite.
Yeah.
And you will see, Joe, and there is no difference in mortality here.
That's
as opposed
interesting.
to recovery. Absolutely no difference, right?
There is no difference, and the follow-up is 2 years. Of course, they go up to 5 because the enrollment criteria are low, but see, the idea is that a good follow-up, and at 2 years, there is no difference in mortality, but, the numbers, as you see there, are 3.6 for TAVR and 2.7 at 2 years for conservative therapy.
Yeah, low rate.
So this is a 1% in the wrong direction.
Yeah.
At 2 years.
Yeah.
And so the question is that really we made, because most commonly when patients come to you to say that you want to have severe AS and you want to have TAVR or whatever treatment, they are asking not so much for rehospitalization or for anything else, but they are asking that they are going to die. So what this trial tells you...
Well, let's take a look. Go ahead.
Stroke. So stroke is interesting. At 2 years, there's start to be some numerical difference with more stroke with the clinical surveillance versus TAVR, and the curves continues to diverge. So it's not, there is a trend, it's not statistically significant. But you will see later, I will show you rapidly the meta-analysis of the 4 trials, and in the meta-analysis it becomes significant for stroke in favor of early intervention, okay?
But 1 second before that.
Yeah.
So in this trial, there are people who cross over.
Yes.
So remember that when you are talking about stroke, the stroke could be from a crossover.
Sure.
So this is an intention to treat trial, and now you are telling people that you are asymptomatic. So they are stressed out that they are saying that half of the people are going to TAVR, half of the people are not. Please.
That's a good
Come on.
good point. That
Thank you guys for being on time.
That's
All right,
This is, I can bring it. This is all about timing, so this is late TAVR.
All right.
No,
It's getting late. We're all punchy.
no, that's
I think it's probably AFib, or else it's crossovers. Go ahead. Next slide.
yeah, okay. So unplanned cardiovascular hospitalization. This is actually the component that drove the differences. Okay, there is no difference in mortality, no difference in stroke. So essentially, the difference that you have in the primary endpoint is driven by the unplanned cardiovascular hospitalization.
Listen, surgeons don't like this slide. Repeat hospitalization means nothing to us, and yet this drives every trial.
It's the early TAVR trial.
This is early TAVR.
Surgery has nothing to do with
I
it.
know, but in general though, right? Across the board.
But I mean,
Procedurals, how about procedures?
exactly. But it's in the first 6 months that it occurs, because according to the design of the trial, a conversion to AVR in the next 6 months following randomization was considered unplanned cardiovascular hospitalization. And as you will see, we had about...
So this is exactly the same distance. So 15% of the people, you will see it, were crossed over. So let's see the crossover, so you will see. The next slide, I think, was crossover, right?
No, next slide is an important one, because in this one, it's the composite of mortality, stroke, and heart failure hospitalization. So it's only the hospitalization because of heart failure, and okay, the difference is numerically less important, but still significant, okay? Then there are other endpoints. I will go fast on that, but it goes in the same direction. The health status outcome that was defined based on the KCCQ more than 75, and that did not decrease more than 10 points. Better for TAVR, 86.6% versus 68%. Same also, we had an integrated left ventricle, left atrial health at 2 years. That was a several criteria. Global longitudinal strain more than 15%, no LV hypertrophy, and no LA dilation, which was also better in favor of TAVR than clinical surveillance. The rest of it was not significant. And this is where the patients were classified according to the acuity and severity of signs and symptoms. So of course you have the asymptomatic. A few patients, as we'll see, will have conversion to AVR in the clinical surveillance arm, of course, while still being asymptomatic. Most of them have progressive valve syndrome, what we call progressive valve syndrome. So it's functional class 2, increase in heart failure medication from baseline, some increase in BNP between 1.5 and 3. So that's progressive, less severe mode of presentation. And then you have the acute valve syndrome, where we are talking about NYHA class 3-4, syncope, atrial fibrillation, ventricular arrhythmia, resuscitated sudden death, LVEF less than 50%, and markedly elevated BNP, so more robust. And this is what we call the rainbow, with Philippe Généreux, the rainbow curve. So this is really the rate of conversion to AVR, only of course in the clinical surveillance arm. And first notice that in the first 6 months, you already have 1/4 of the patient who converted, and explaining this large proportion of this unplanned cardiovascular hospitalization that you see in the primary endpoint. And at 2 years, 47%, almost half, had already converted to AVR. And then by 4 years, it's almost 100%. So you see, this shows you the proportion of the patient who converted because of acute valve syndrome, about 1/3. The vast majority was progressive valve syndrome, and very few, that was the good news, without symptoms. Because, you know, every cases that had to cross over where the site thought that was important to do the AVR had to be adjudicated and confirmed that there was a progression to severe AS. So I'm showing you the survival curve. This was not presented at the time of the primary presentation. This is something that we recently presented and that is in press. But this is the survival curves of the not of the primary endpoint, because this is mortality, stroke, heart failure, hospitalization, so kind of a somewhat more robust, I would say. And you see that if the patient presented with acute valve syndrome, clearly there is a higher rate of this endpoint, whereas if the patients presented with progressive valve syndrome, the outcome was similar to the patient in the early TAVR arm, who of course had the TAVR since the beginning. And you see also a kind of similar impact on the integrated LV-LA health, where you see a decrease in this health status of the left ventricle or left heart from baseline screening to pre-procedure in both patients with delayed AVR with progressive valve syndrome versus acute valve syndrome. But with acute valve syndrome, you see that the drop is more important and there is less recovery in health status. So you pay the price also in terms of ventricular health. So the conclusion, we know them. The TAVR, early TAVR was superior to clinical surveillance versus the primary endpoint. The early TAVR was not associated with excess mortality or stroke, so appear to be safe. And the implication is that considering the clinical benefits and lack of harm of early TAVR compared to clinical surveillance, this provides support for early intervention in these patients with asymptomatic severe AS. And early TAVR is really all-comer patients.
So you think this is going to change the guidelines?
So
I don't think so. It won't. I don't think this is strong enough for Class 1A indication.
No,
I think my crystal ball, 1B. Well, sure, because if you take the early TAVR, it's one thing, but if you look at the 4 trials together,
2A. Go ahead.
1B.
I think it'll be 1B.
But if you go back 1 second, so
Yes, sure.
the few questions are, so as you showed, that this, go back to the acute versus non-acute, so the yellow versus the green, yellow versus the red, the definitions.
Definitions?
Definitions.
Yes.
So my point is that most of the patients who were yellow did okay, in the
Yes.
sense that there was no difference in their outcome.
No, that's what I showed, yeah.
Yeah. The acute syndrome, when it happened, the acute valve syndrome, it is really bad things. So the question that is important to understand is that who are these patients? Could we predict from because what is so critical about 4 meter per second jet? So there may be patients that, like in moderate AS, we are testing this, but the main question is that this was all comers trial, but only these people, this was about 25%, if I recall it right, who were in this category.
Yeah, so we are trying with Philippe Généreux now to to try to predict those patients who are going to present acute valve syndrome versus progressive valve syndrome.
Exactly.
We were thinking that maybe blood biomarkers, because as you know in Early Tower we have a biobank, and we just have completed the analysis. But actually this has been a bit disappointing because the blood biomarkers are not able to, blood biomarkers at baseline are not able to predict those patients who are going to progress, well, we're going to present progressive versus acute valve syndrome.
Exactly.
It appears to be difficult to predict.
How about in echo-wise? Nothing?
Echo, we are still into that, so we are not yet done. So maybe echo will work, we'll see.
Because I think the flow is the predictor. So if I see patients in my clinic
Yeah.
who have severe AS, which are the patients I feel uncomfortable with? So if the flow is less, then I am uncomfortable. If LVH is very high, then I'm uncomfortable.
Flow, cardiac damage, you know.
And
maybe
LA size.
Yeah.
These are the three things that you really worry about, and of course biomarker, NT-proBNP or something.
And
But
maybe
they-
global longitudinal strain that we
Right.
also measured in, yes, absolutely.
But these were not yet, we don't know that.
Go back to that previous slide. Are you able to, right there, that's death, stroke, and heart failure hospital. Is that broken down into?
Yeah, death and stroke are no different.
No, I'm talking about,
For this one, where you have yellow, red.
Yeah, but it was never powered to look at this sub-analysis.
that's-
This is a secondary
that's the
look.
thing, yeah.
And if you go back to the red, go back to
To
the
look at, is
the definitions.
that more,
no, it's
in
like,
that red
so-
group, is
so
it death,
it-
rehospitalization, or stroke?
It would be nice to know within the acute valve syndrome, how many of them actually presented with some hard measure rather than just NYHA 3 or 4.
Yeah.
Right?
Yeah, sure.
Sorry, if all of those patients actually had a demonstrated heart failure hospitalization or a drop in EF or something, those are probably the patients who are actually benefiting. Because the thing is, on the whole cohort, when you take the whole cohort into hand, you know, the primary outcome is biased by the soft symptoms in patients who are already primed to be worried about it. And that's why the crossovers continue to occur. And so it would have been, you know, really informative to know in more detail what percentage of them presented with hard symptoms instead of just NYHA 3-4.
Samir, when you say that this is the highest crossover I've seen for a device in a while, but 75% by 1 year, right?
Yeah, but you know what, in the,
What was it in COAPT?
yeah, but
No, COAPT at 2 years, we had to wait. We could not do it.
It was a 2-year crossover, yeah.
But this is not device versus device.
No, I said device.
This is device
I know
versus
that.
medical therapy.
Yeah,
It's a whole
this is-
different ballgame. You're going to get a terminal.
What was device versus medical?
Medical therapy, COAP was device versus medical therapy.
Yeah, yeah,
We didn't
exactly.
put,
You're going
we
to get a
didn't
lot of
cross over.
crossovers. That's the nature of the beast. So the fact of the matter is that this is not that different from recovery, A. The results are fairly similar. You have an 85% crossover by 3 years. I don't know what you learned from this, except for what Samir said, which is how to parse out, and what you said, which is how to parse out the red sign. But bottom line is there's no death penalty to watchful waiting. There's no death
Exactly,
penalty
this
to
is
watchful
my
waiting.
point. So
That's very different from every single study looking at AI, for example, where if you stick with class 1 and class 2A triggers and you go with them, you have a death penalty, okay, for that. You don't have a death penalty here for watchful waiting. That's the key concept.
This is exactly what I was saying, so that you don't, that's why I think that 2A will be the indication, because I think that you can put 1A, but 1B, but I think that since there is no death penalty, and this is what most patients are worried about, and if you show here,
there is no death penalty for waiting, but there is also no death penalty for intervening early.
no, but you start the clock early, right?
Not
This
yet,
valve
true.
is not a valve that is going to last for a lifetime. So, of course, there is a
But then
penalty.
wait for the slide I'm going to show later.
But once-
There is no death penalty, but there is a stroke penalty.
Exactly.
That's a negative trial.
The stroke penalty is hard to say because so
may
many
get it out
crossed over, so you can't say anything about that. The thing is, this is going to embolden people to put in the implant TAVIs into patients who are asymptomatic, who are young. And we are all forgetting about the trade-off of valve-related complications. It's going to be a tsunami in these young asymptomatic patients who could have been totally well and they have degenerating valves or
Well, that's the other problem.
thromboembolized
There's no,
or valve
this trial needed a
thrombosis
surgical
or-
arm.
Remind me the
This trial
age.
needed a surgical arm.
65 and older. Now, but one question, so do you know that
the
how
hearts.
many were NYHA4 and how many were others?
No, in the acute valve syndrome? Not
Yeah.
necessarily. No, because the problem that we try to, do some subgroups, the problem, you're stretching the sample here. Because remember, these patients are only the clinical surveillance ones, so you're cutting the sample in two. Then the acute valve syndrome, this is 1/3 of the clinical. So then you have all the small subgroups, so finally, it's
No, but
difficult
just
to make-
NYHA.
Yeah.
If you just separate NYHA.
Yeah, I don't know.
You don't know that.
No, I don't know how many,
That's
only
new.
at the
That's
NYHA.
new atrial fibrillation.
The good news is, now we don't have the big room, we have a little room, and now you guys get a window of what really happened, like it's really fun, isn't it? This usually happens with red wine at a big table, it's more fun that way, but this, we're gonna make do right now. Yeah, we're gonna make do right now.
And don't be intimidated if you want to come to the microphone and interject, because obviously here you see there is some passion in the discussion. So that's great.
Yeah, that's okay, we have plenty of time. Because
I just don't think this trial has added that much to our knowledge base here. There's no death penalty. I can't imagine this is going to be informing the guidelines at a level 1. Basically, everybody is in the treatment arm by 2 years.
Well, but I'm going to tell you right now, I mean, the plan with the industry that supported this trial is to open up the NCD based on this study.
Yeah,
You know
well,
that, right? Because it'll change it from symptomatic
This-
AS, which is what it says in the current US NCD, to symptomatic or asymptomatic.
Yeah, but Dina, this is what I wanted to ask you, and I'll
I'm
ask
not-
both of you. No, I'll ask both of you, because this is exactly why I came over here. Was not to make it talk about, I'm happy to talk about triclip, but I'm more interested in this topic. Why are we bothering doing these trials? I'll ask everybody. Why? Because the day it's released, no one cares about any criteria, they just all go in. And I'll give you my example. You showed a slide with MitraClip. MitraClip, more than surgery, give me a break. The heart failure doctors never bought into MitraClip for heart failure. That's why they never met the numbers. No, it was degenerative patients driving that. What was the indication for degenerative disease? An STS of 7. The number of patients with an STS of 7 is about 1% of the U.S. population. And what's happening and what the fear is and what was already brought up, trials like this open the door to, yes, of course, in the trial we're going to be very sophisticated and document the function and document this and document that. The day it's released, a 57-year-old has moderate AS, a little bit of calcium, a bicuspid valve, otherwise, just maybe he was dehydrated, it was a hot summer day, oh, you were symptomatic, we're booking you next Tuesday. That's what's happening. And one of the things that you're feeling is that this is a process. I'm so sick of hearing the word heart team. Most hospitals don't have a heart team. If you get off on the 5th floor, you get one procedure, you get off on the 2nd floor, you get another procedure. Now, we need to get there, I hope we do, but we have to be very, very careful because evidence currently does not drive most clinical practice after release of products. I bet the panel will agree with me.
yeah, but that's why you need to have really good guideline teams, and the guidelines need to be really sophisticated, but
I don't think it's anything to do with the data. I honestly think this is the reason to open the NCD.
No, but I think that my
It doesn't matter
point
what the
is
data
that,
is. That's what it's
again, is it going to change your practice? This is the question. So before you saw a patient with aortic stenosis,
this is not going to change
No,
practice.
progress
what did
trial
you do?
would,
Let's say
but this
that
won't.
if you had a patient before early TAVR,
Before early TAVR,
let's say you have a patient with a 40 millimeter mean gradient, asymptomatic, and you put in a treadmill, remains asymptomatic. What did you do?
if there is no fast stenosis progression, the stenosis is not very severe, BNP
No,
is not
severe
very-
is severe.
because it's
Severe, 40.
And your
Yeah.
Vmax is
So, and there is no
4.1.
other risk marker, so you have no 2A indication according to the guidelines? Well,
I would wait.
You should do watchful waiting.
Exactly.
You see the
And then
patient back in 6
now
months.
what are you going to do?
The problem with that,
No, my question is, now,
You're going to
how
do
is it
exactly
going
the
to
same
be
thing.
different?
I'm with you.
should
Samir, I'm with
maybe
you.
consider intervention.
I can't believe I'm agreeing with the cardiologist, but I'm with you.
No, because I
No,
think,
but the thing is, in reality, in real practice, you say the patient, come back to me when you have symptoms. Most of the time, they don't come back to you, especially when they are NYHA2. They will come back to you when they are in acute valve syndrome. But you see, when you have acute valve syndrome, then the outcome is much worse. That's the issue.
That's the issue. So if you have a good patient,
If you have a good patient that you ensure is going to come back.
that's, I agree with you. That's what I did before too, that say that there is
Because
a,
I see the practice from Canada and France, and the people are telling, we don't trust the patients.
but I had an ophthalmologist I followed for 40 years with a high gradient, 40 years, completely asymptomatic. Every 6 months he comes and does a treadmill, and he's asymptomatic. I said, what
Fine,
is the
that's
urgent?
perfect.
So 40 years we got from his old valve. And the LVH remains the same, and we ventricle, everything same.
Treadmill and BNP?
Yeah, but let's
BNP.
just be honest. This is a negative study, okay? You got
Okay,
no-
let's see your data to say.
So wait a second. So Samir, I just have a question for you.
So-
There's 800 sites that do TAVR.
So-
Okay, do you believe that your practice is the same as every other cardiologist in the country? I would beg to say that 850 out of 851 sites, maybe excluding, well,
No, it's true that
840,
a lot of people are
840
doing
sites. So
unnecessary
take out,
things.
no doubt about it. This will
I have
be,
no doubt about it, but this is the same thing like a LAD stenosis, right? They call me and they say, I have 70% stenosis, should I put a stent? I said, please send me the film, because when you look at the film, it doesn't look 70%, it looks 50%. So same thing, the gradient they measure, who knows what is they measuring?
Right.
So all of those things
Yeah.
are a different question.
So 4 trials, 3 positive met the primary endpoint, 1 negative. Evolve did not met the primary endpoint. The main reason, I think, is if you look at the median time from randomization to AVR in the Evolve, it was 5 months. So it was not really early AVR versus 2 weeks in early TAVR. So that might be the reason. And that's the results of the meta-analysis I would like to share with you. We published that recently in JACC. So that's the meta-analysis of the 4 trials. So there is superiority, of course, for unplanned cardiovascular hospitalization, heart failure hospitalization, but you see also stroke is significant here when you do the meta-analysis. And most of the stroke occurred after the AVR, following the conversion, with the hypothesis that when you do the AVR later in the course of the disease, so with more advanced valvular and maybe aortic disease, you have a higher risk of stroke. So it was not stroke prior to intervention, it was stroke often, most
After, most of them, right?
Yeah.
So this is a question, so like, there was a hypothesis 10 years ago to say that let us put a stent in the LAD when it is 30% proximal, because the MIs happen in 30% lesion, and if you wait till 70, maybe you should be too late.
Yeah.
So they wanted to put, no, I'm not joking. This was a trial that was designed, and they wanted me to participate. I said, I cannot participate. This is, it doesn't make any.
preemptive stent.
Right, so like put a new valve before they're born, or in the pediatric or something. So that
Why don't you do
as
it- why don't you do it
early as you
everybody?
go is better. But how far can you go?
So my conclusion, I put money on 1B, but I may be wrong. I think it's going to be at least 2A for all comers. All comers with, but I think with the meta-analysis, the 4
No, it
trials, it
shouldn't
might be
change.
1B. But I may be wrong. I think, but you see my last sentence, despite the result of the trial, because as you just said, I mean, you may have a tsunami. So I think we'll still need to continue to individualize, prioritize, and maybe, just as what you said, treadmill every 6 months with BNP.
Yeah, that's
in a
right.
compliant patient, that's fine.
And a good echo to see if the LVH is getting worse. If the LVH is getting worse, I think it's a good reason to do
That
something.
was headed for, okay, agreed, okay.
To put more oil on the fire, as you know, there are ongoing trials now with at-risk moderate AS.
but-
TAVR note has been published, we're still doing progress and expand TAVR 2, but that would be for another time.
And all of them have an endpoint at 1 year or 2 years. So
No,
this,
yeah, 2
2 years. Yeah, so this
I
is,
tell you, it's very, very rare to get a guideline extension, especially at 1, maybe even 2A, when you don't have a death benefit from this. So I don't know.
And stroke benefit?
the stroke benefit is after the procedure.
The stroke benefits.
So you're causing the stroke.
Yes, of course.
The stroke benefit's too
Yeah,
messy.
it's after the procedure, but it's related to the timing of intervention.
The stroke benefit's too messy. Yeah, it's not clear enough. Anyway, it's a great trial. See what happens.
It was fun.
Your thing.
All right,
Trial
good
it.
show. Next.
It's your turn now.
Davide.
And I haven't tried, and I had nothing to do with it.
I just want to make sure I understand one thing, because Bavaria is so active, which is lovely. Joe, what's the penalty that we won't know until 10 years of all the failed TAVRs?
I totally agree with you.
That's why I don't understand.
5
It's
years.
gonna be
what is the
dramatic.
rush?
5
This,
years.
and again, this reminds me, and I will say it now because we didn't have time to say it before. I'll ask Fino. That's what I mean. We don't have a schedule. Welcome to the party.
Yeah.
Fino, what problem are we trying to solve with low-risk MitraClip? Like, I get everything. Here we were trying to see if patients live longer. We're trying to make people feel better, as you'll see with Triluminant, not live longer, because that population. But what are we trying to, what exactly are we trying to solve? Because the same people that will tell me, MitraClip, we need this trial, we need this trial. Let me tell you something, I'll see if Vino agrees. I believe that trial was a defensive trial. Unless we do this trial and try and prove surgery works, all the cardiologists will clip everybody, talk about TAVR everybody. I think, based on the data so far, I just think people think if you just have a mitral valve and you're over 60, just get a MitraClip and all will be well, because every trial shows, now everyone says 99% of people don't have mitral valve regurgitation and all this, and I think that, I get all the MitraClip for heart failure, because you didn't live longer with surgical ABR. You only felt better. So now you make people feel better. You don't have to live longer. But with mitral valve surgery, low risk, 2 or 3 week investment, same people that preach robotics, it's not even heart surgery anymore. It's just a robotic operation. You don't even touch the mitral valve. You just get a robot inserted, and you start playing golf again in 3 weeks. But now we have MitraClip. You won't have to take 3 whole weeks. We can give you this thing that destroys your physiology, changes direction of blood flow, and we'll see what happens, because we'll have a 2-year endpoint or
Yeah.
a 4-year endpoint.
Well,
How are we doing that?
not as the originator of either trial, the repair MR or the primary, I don't disagree with you, David. And I think that, in low-risk patients, I have to be honest with you, when I re-operate on these clip patients, I'm replacing most of them. Honestly, I'm not repairing them because they're so scarred in, and I just don't do it. So I don't disagree with you, David. I think it is, listen, somebody trained with you came up with one of them, and the other one was, Pat McCarthy at Chicago. The point of it is that I think they're defensive trials. I think there was an absolute scare that cardiology, no offense, Samir, that cardiology was going to take over primary degenerative MR. They wanted to show that how good or bad it was. The problem is that when the trial gets published, in my opinion, no data to prove on this, they will both show equivalency, and the reason is because the absolute patient with a beautiful P2 prolapse will get a clip, because anybody with a P1 or P3 or a cleft or a P1 P2 or a P2 P3 or A3 P3, all of those patients will be kicked out. And so but when people, the general community, there's 500 sites in the U.S. doing MitraClip, they will just say, non-equivalent, now you can do whatever you want to do. And it'll become a shit show. And I think that's a problem.
Okay, now I can say why, I agree with you.
We should have chosen a different triluminate than mitral. Mitral is more controversial than tricuspid.
No, but tricuspid. But one problem that people were trying to solve, just so one question, is that mitral repair is extremely institutional or expertise dependent. So when you want to say that certain thing is outstanding, very good, I agree with you, it's outstanding, I believe in that. But on the other hand, is it generalizable? So if it is not generalizable, which I don't think is generalizable, if it is not generalizable, then you need a device or you need something that average people can do. So this is where I think the question comes up sometimes, not because one therapy is better than other, but one therapy is more generalizable than the other. So this is where I think there is a point of this. Now, of course, these trials are designed by a defensive mechanism, but still, this is where I think personally, this is a good reason to do it.
Well, again,
Let's hear you talk. Wait a minute. Let's go ahead. Let's hear
I'm
you
going to talk. I'm going to talk, but I'm going to respond to that. Listen, Samir, The answer isn't, it's hard, therefore let's just lower the bar and let anyone do it and we'll take what we get and we'll see what happens. That's not the answer. Like if I need a cancer operation and they tell me, well, you know, in my center, we're going to leave a little cancer behind, but we got chemo and we'll have a few years to see if that gets it. Or you can go 100 or 200 or 400 miles away and be cured of your cancer. I'm going there. And I bet you're taking your son there, and everybody in this room's taking their child or mother or father there. So this nonsense that it's not generalizable, therefore we'll clip everyone. And when it goes in the Wild Wild West, there won't be talks about clefts or annuli or calcification, and which is exactly, by the way, one of the reasons the heart failure community has not embraced MitraClip. If you read the COAP paper and saw the palm trees and the hosannas at TCT, every heart failure patient would have their thing relieved. The reason it's not is not because we don't believe the evidence. It's because as soon as people started trying it in the real world, they didn't get the 1+ MR every time. My own heart failure doctors tell me that. In fact, one of the most important cardiologists, interventional cardiologists in the world told me that. It doesn't really work that well. That's why we're not that big a believer in it. So yes, you're right. Let's call it what it is. It's a palliative therapy. It's not a curative therapy.
But it's not generalizable, that's why it didn't work.
Okay, so we can generalize palliative therapies, but we should make sure every patient...
No,
knows
because the
palliative,
MitraClip was not
curative.
generalizable because it is very person dependent. So I agree with you that it doesn't work, that's the reason.
Let's do something not controversial, the triluminate trial. How do we pull these slides up, guys? I've got it on my screen. How do we
It's
get it
a
on the big
duplicate
screen?
or something. Display and duplicate.
Here it is. Oh, here we go. Okay, so now we're going to talk about something that shouldn't be controversial. It's actually very controversial, and the reason is because of what Jay said, there's no mortality benefit. But we'll talk about the clip in the tricuspid position. And I want you to understand the parallel of that. As strongly as I feel about MitraClip, and I do think my voice has had some role in changing trials, because I think people have gotten a little more focused on what the goals are. How did the same person get involved in the TriClip trial, clipping tricuspid valves? Well, you'll learn that along the way. Those were my disclosures. I was one of the national co-PIs of the trial. And I'm just going to briefly run through this to show you what we were trying to do. We were trying to use clips for severe tricuspid regurgitation. We had two arms. We were flying solo. No one had ever done anything like this before. The randomized arm would be people we thought we could get to moderate or less. Please don't get confused with mitral regurgitation. Tricuspid moderate regurgitation is still left alone in many heart centers when they operate on them. There's no indication to repair the moderate tricuspid regurgitation, at least it's not been accepted yet. So we said moderate or less, and the single arm were people we thought we could decrease it by a grade or two. Remember, tricuspid regurgitation, we were going to employ a 5-score grading scale because there's severe, massive, and torrential. That was Becky Hahn's criteria, and it is true that you do have varying degrees on the right side of, because massive or torrential MR usually you don't do very well. That disease you can manage and sort of live between there. You had to have severe TR, you had to be on medical therapy, and you had to have an intermediate risk of mortality, which of course every single patient had. These were all the things, all the sites and all the people. There were multiple individuals that did this trial, and it really was, I think, a very well-run trial. It was a randomized cohort. The primary analysis was going to be 350 patients. Once you qualified based on the echo and the other criteria, then you were randomized 1-to-1. I'm showing you the New England Journal paper without the data because we'll look at the larger cohort, because then of course we looked at the 2-year outcomes in a larger cohort. But suffice it to say, there was significant benefit. We decreased the tricuspid regurgitation actually very effectively. 50% of patients had mild or less, and about 85% had moderate or less. That was including treating massive and torrential TR, really massively dilated tricuspid annuli and tethered valves. But the primary analysis won because of KCCQ. There was very little, there was no difference in mortality, no difference in hospitalization. It won on KCCQ. We'll get back to that in a minute. Let me go through the study here quickly. These patients were 78, 40% that had these were repeat cardiac valve interventions. They'd already had prior interventions. And you can get the hang of this when you look at that. 60% were female. These are not patients who are jumping up and down to operate on, unlike 60-year-old P2 prolapse. These are patients that actually are very high risk for tricuspid surgery. And you know the STS showed a predicted risk of mortality in this subgroup of 6%. I think the last STS paper was 7.2. I can't remember looking at the database, but it was over north of 5%. They're high-risk patients, and then you can see the number that had torrential TR. So really, this wasn't one where you have to sort of look carefully to decide if they have TR. They have lots of TR. There was the reduction of TR at 1 year, and you can see why I said 90%, 88% had moderate or less, about 50% got to mild or less. So it was actually effective treatment. There was no difference in mortality and no difference in hospitalization. So heart failure rates, mortality rates, not different.
Go back to that slide again.
Which one?
The one with the heart, yeah.
The next one.
Wow, the one behind that, yeah. No, go ahead, forward, yeah.
Okay, so
It's amazing.
what's amazing?
So no change in the hardcore stuff.
No change in hardcore stuff, only KCCQ, which of course has a Hawthorne effect. This was a big part of the FDA panel discussion. We went to panel. Some people didn't. We went to panel and actually defended the data in front of a lot of other significant group of people, which actually was quite informative and fun for me. And just like I mentioned in the other room about one of the other trials, you see this win ratio. The win ratio is all based on KCCQ. That's the primary endpoint. When you want to understand data, you have to look at the primary endpoint. You also have to remember that the primary endpoint is usually made up, particularly these days, of multiple subcategories.
Jesus Christ, it wasn't even a heart failure improvement.
Oh, there it is.
That's fucking unbelievable.
See, that's the beauty of small rooms at 4 o'clock. You can really say what you think. Here is the 6-minute,
You must have lied your way through this at the FDA. I love it.
not at all.
No, there is more data.
No, not at all. But I wanted to show you that, just wanted to get you through this last little bit about the what happens when we added more patients. Because, for example, if you watch this data, and I should have said this to you, these are now the 572 patients, because we had the roll-ins continue as we were continuing to enroll. So when we finally had enrolled 350 patients, we obviously had, or when we finally got to the 1-year endpoint, we kept enrolling patients. So now we waited another year to get more data. So look at the 572, how that didn't change, right? Mortality didn't change. Heart failure hospitalization sort of flipped. It wasn't really mind-blowing, but at least it started to make more sense. Remember, this was only 2-year data. And this was the 12-month KCCQ. Again, larger patients, not significantly different changes, but consistent changes. One thing that I don't have time to go into that we can talk about was the crossover, because we allowed crossover at 1 year, because the physicians felt so strongly at the beginning of this trial it was a mistake. We couldn't talk the group out of it, so the majority ruled, so we allowed crossovers in a year for people that were randomized in the non-clip arm. We probably should have held on for 2 years, and I think we probably might have seen a mortality benefit. And then that was the total win ratio, again, like I showed you. And the 6-month ratio actually flipped over now. And one thing I'll say about this trial is that a lot of this, and there's a lot of data about the KCCQ that was published, including a sub-analysis of this. To me, it wasn't, at the end of the day, looking back, it wasn't so surprising. We never do tricuspid valve surgery and promise patients they'll live longer at 1 year. What possible evidence has ever existed that if you operate on a 78-year-old that has massive or torrential TR and you fix the TR and now you'll live longer at 1 year? It's an insidious disease. It doesn't kill you in 1 year. It's not like symptomatic AS. So we shouldn't have been surprised by that. I thought the heart failure hospitalization would change. That didn't change. The medication sub-analysis didn't change a whole lot. So it wasn't completely clear what the physiology was. However, the TR reduction was substantial. And one of the things that was really important in this trial was the safety. And I want you to remember that I don't know whether we're talking about it today or not, but one of the things I want you to remember is this procedure was done with no procedural mortality. There was one mortality in the 572 patients in hospitalization. that's remarkable when you think about the predicted STS score over 5 at a 0.2% mortality rate for the whole cohort. So it was incredibly safe versus open surgery, and the complication rates were actually exceedingly low. So you had a very safe, this was one of the arguments with the FDA, you had an incredibly safe reproducible procedure. We did sub-analyses of all of the centers versus high volume versus low volume. That's what the FDA wanted to understand, was were there a difference in outcomes and mortality risk versus centers that did less than 5 versus the top 10 enrolling centers. So all of this data was part of that thing. So you had an incredibly safe procedure that effectively reduced the TR, an incredibly soft endpoint in terms of the endpoint that can be the most impacted by subjectivity.
No, that's the problem.
KCCQ.
Because, I mean, you know, there is a difference in KCCQ, but there is only a difference in KCCQ, nothing in heart failure. And with this design, it's not like if you would compare two devices. You compare someone who got the fancy device versus a control group who knows that they have nothing. So there is a huge placebo effect or intervention effect in this type of intervention. And the treating team also knows, oh, you got the clip, so you probably got to get better, you know. So I'm kind of, if there would have been a signal, at least for heart failure, it would have been more, but here this is like soft, you know.
Of course, and remember,
I don't even know, soft is not the right word. I have to find a better word for soft, spongy, or...
But let me, 1 second, just to defend this one piece. I agree with you. So when we saw the data, and as Dr. Adams knows, I'm part of the study as a disclosure. So we went back, and with David Cohen, myself, and Susan Arnold, we looked at the data to say that, listen, if the KCCQ, because I was very skeptical, because there's no heart failure change, no mortality change, and actually if you look at the ill effects, like renal failure is worse in the people who got the clip. Not high, worse in the renal failure was worse. So the question was, not the baseline, but ultimately. So the idea was that if we can just compare the people who got better with the amount of TR reduction. So let's say your KCCQ increased by 15 points and your TR reduction was 2 difference, and if your KCCQ increased to 30, then so this is what we try to do as as a skeptical people, and we published in JACC to say that there was a correlation. Of course, it does not prove, good one. It was fairly good to say. Of course, I personally don't even believe that the amount of TR reduction is very well documented, because again, the people reviewing the echo core lab sees the clip. So what they call a TR is also questionable, because I think the TR assessment is very questionable.
Split into a million jets.
Huh?
Split into a million jets.
Split in million jets, and also what you call torrential and mild and severe and moderate and all this.
So here's the main question. Do you think if you presented this at the Heart Failure Society, would it change anything that they do? I think...
No, they're sending us a lot of patients, just so you know. So there is
They're more open about TR patients coming and there are mitral patients coming. So what you said, David, I think earlier on the mitral part of heart failure is not the case with TR and heart failure. They are sending us a lot of patients. I agree with Samir on that.
And again, I think having been on these journeys in transcatheter trials since 2012, one thing that's come up in 13 years that we don't talk about enough on podiums, when you're young and you're asymptomatic and you have a long life expectancy, the bar should be extremely high, and there is no reason, and it should never happen, that there is a class 1 indication on 1 or 2 year data. Many surgical valves have been approved by the FDA that are off the market after 7 years. So class 1 should only be reserved for a minimum of 5 years of follow-up, or we are really potentially harming patients. That's number 1. Number 2 is, we have to think differently. Joe said it correctly. We need different guideline committee perspectives. That is, if we are dealing with, this was the single arm, you're 80 years old, you have torrential TR, and you're very symptomatic, and a heart failure doctor wants to send you to this trial, I think the bar can be pretty low. If you're a 60-year-old with bicuspid valve disease, I think the bar needs to be exceptionally high, including pacemakers. I don't want a pacemaker, and now we know there's survival penalty.
Yeah, but
See,
I will say,
you can't
Dave-
have them both ways. We've got to start thinking about it differently. When I was in the TAVR trial, running the core valve trial, or helped one the surgical PI of that, I tried to get the FDA to agree to, if you're over 80, you're in. No STS requirement. I think if you're in your 80s, you got 5 or 6 years to go, you should do whatever you want.
But David, you know, if you look at,
You got to have a lot of criteria.
but one of the things that we in surgery, and I was also part of Triluminate and on the publication committee, but the one of the things that we haven't done, where is tricuspid valve surgery in the guidelines? Isolated tricuspid valve surgery, where is that in the ACC/HA guidelines? I'm asking you.
No, it is not.
It's nowhere.
Nowhere.
So my point is that we,
2B indications.
yeah, come on, 2B is not, I mean, that's shit indication. Okay, let's just be honest. So I think that we need to do a good job in presenting the data or doing trials, randomized trials in tricuspid management. David, by the way, I published a paper in the Annals on the tricuspid score. The ST score is 5.6%.
5.6.
So 30-day, 5.6, that's better than the 9% that it used to be. So we've cut, surgeons have cut the mortality about 80%.
That's why I did Becky when she tries to tell me it's 12,
So
15%.
I'm just saying that that's part of the thing that's, my cardiologists say to me is, we know your outcomes are great, but guess what? We like, you can't choose guidelines when you want to choose the guidelines. If we go by the guidelines, you guys surgery are 2B. And so it has backfired a little bit on me personally in my center, because they come back and say, look, the guidelines don't do that. It'll be interesting where the new valve guidelines put TriClip, in my opinion.
And by the way, just so you go, just moving forward to the punchline, this shows you what I mean. I said you weren't very good at predicting, because remember we thought the single arm would have a lot, mostly moderate MR. We'd go from torrential to moderate, but actually
TR,
the TR, but we actually almost got to the same thing as the single arm. So we weren't very good at predicting who was going to do well versus not. And so again, I think the therapy, and we'll get to the discussion here in a second, I think notice the mortality was higher in the single arm. They were sicker patients. They were older and sicker patients. But I think that the punchline here is that so far we have treatment that can minimize MR and TR in most patients with minimal risk. Very low risk compared to, example, the EVOQUE trial. Much lower risk. So we have a very low therapy. It's not as effective in terms of eliminating the TR, but tricuspid valve replacement will eliminate in everyone. If you walk out the door, you're not going to have TR. You do pay a penalty for that, at least in the current iteration, but I do think that our I do think that this field is going to evolve. This was the Arnold paper that Samir was mentioning, which was a very careful analysis. A lot of, obviously these studies generate numerous papers. This study was the one that sort of showed the KCCQ benefit to the degree of reduction. This one was the high-risk anatomy paper, and I showed you Paul's, and this thing did get approved. Where it goes is the question. And I think where it goes, personally, I'll start. I think where it goes, I hope, is a 2B indication. Because I think that's what it is. I'm happy with 2B.
It may help, because I think 2B means may or may not help, but 2A, at least it may help.
I'm happy with either one, because frankly, I don't think half the world knows what they mean. I think class 2 means it might be beneficial. We don't know enough yet, but again, that's where we'll have to, use our human intelligence and look at the patient and decide. And I think this is where, the other thing I'll just say about the patient, their life, their quality of life, their life expectancy, their predicted survival, and the strength of the evidence. There's a whole circle you have to think about every patient. For example, we talked about the early TAVR trial in asymptomatic AS. Hopefully that's not for an 87-year-old that gets wheeled in the wheelchair because someone heard a murmur in the nursing home and now we're going to put a valve in. But that's my worry, is I think, and the same thing here, I think that there are going to be patients where you probably think it might be worth it, and there are going to be patients that I think what will happen one day is we'll have patients that have massive interventional TR. The heart failure community doesn't like these patients. They're actually hard to manage. They are pretty miserable. They have lots of symptoms. And you're not really expecting to cure, at least at the time we're treating them now, we're not expecting to increase their survival. We're trying to make them feel better. Hopefully, we'll simplify their medical therapy. And
Yeah,
then
but, you know,
deciding between valve
Samir-
replacement and repair, I think it will be based on anatomy. If your anatomy is suitable for clip, you get one. If it's not, you'll get a replacement.
So here, I talked to some of the guys from MGH, and I asked them point blank, right straight to their faces. I said, if you have torrential or severe TR, are you going to put this in, or are you going to put Evoke in? And it was almost 100% Evoke. What are your thoughts about that?
No, this is a good question, but first of all, I don't think that it is that simple, because when we put the Evoke valve, first of all, it has to meet the criteria for the annulus, because most of the torrential massive MR TR patients do not have the size of the annulus that you can put a Evoke valve. Now there is a larger Evoke valve up to 60, but 6 centimeters is also not uncommon with the TR, that it gets very wide. The second is that you get severe RV dysfunction because the valve is so big so that it blocks the annulus, so the annular motion goes down, and all of a sudden the patient has a severe RV dysfunction. And there is about 15% risk of needing a pacemaker. So, and the pacemaker is not a simple solution with the Evoke valve.
And the bleeding and 30-day mortality rate?
And that if you're reasonable, I think the bleeding,
But the thing is,
the bleeding is, to me, it has not been a problem, but the problem to us.
Mortality rate? The
Huh?
30-day in-hospital mortality rate?
No, I agree with you, this is what I'm saying.
What was it? I want Joe to know. What was it?
So 30-day was about 6%, I
So you had
find.
6%.
No, it was 20. No, it wasn't a 20.
Bleeding?
No, mortality.
Oh, mortality.
It was
Mortality. No, but Joe, so
I thought it
here's
was
my
low.
point.
I'll look it up.
See, Joe, here's the point. Guys, I want to say something. Valve repair is hard. I'm sorry. It's even hard with a catheter. Valve replacement should be easy. It would be really easy in the mitral position if we didn't have outflow tract obstruction. So it's harder to do TriClip than Evoke. So if you just ask someone, hey, what are you going to do? I'm going to do Evoke. I have 30 minutes. I heard it in my own lab. It's only 20 minutes. We did it in 22 minutes. Man, move on. Get the next patient. That's not going to be the case with TriClip. You're going to need better imaging, and you're going to need more skill. Having said that, hey, to the patient, you know what? I can do this Evoke. It's really cool. It's going to eliminate your TR. The mortality rate's about the same as surgery. Or, hey, we can try and clip your valve. 80% of the time, we'll decrease it to moderate or less. The risk is 1/4%. You get to pick. What would you
So,
pick?
David, I will tell you though, I mean, with patients send the listen, I'm a part of that other trial too, so the point of it is that referrings do, yes, it has a little bit higher, I'm not going to argue about that, but I am tired of referrings calling me and saying, fuck, this patient still has, moderate, at least moderate TR, and, Dreyfus tells us you shouldn't have any TR, but the point of it is that Sashia told me to say that. I mean, Samir told me to say that. Samir told me to say that. I wanted you to say, listen, Samir made me say that.
But, you know,
No,
but-
the point is,
but, you
so
know,
the referrings do say to us,
Right. So
I have no
they're-
TR,
Yeah.
I have some residual. That does weigh on.
But that's because
Referrings.
we
I
don't,
wanna say-
again,
so-
as a valve specialist, what you have to do is set the expectations.
Yes.
So,
Yes.
when I do hokum patients, you send me the patient, they have severe MR and they have hokum.
Yep.
Everybody leaves the room knowing our goal is not 0 MR. This isn't Barlow's disease. This is hokum. Hokum patients have retracted anterior leaflets often. To be able to completely get the coaptation, I want, I may have to put a patch in. If I put a patch in, that may calcify. Therefore, I'm happy to leave you with mild
Yeah.
MR.
And
I'm
everybody
not
says
going to
okay.
leave you with any outflow tract obstruction.
And everybody
So
says
then when the
okay.
cardiologist calls me, Dave, the patient has mild MR, that's it, the great result. There's no gradient. Not, why does this patient have mild MR? Because you have to teach people what they're supposed to.
I don't disagree with that at all.
I want to say three things.
If you intervene surgically on a primary TR, so let's say it's torrential, and the patient leaves the OR with a moderate TR, are you going to call it a success?
In which category?
Primary TR.
Yeah, but again,
No, because if,
let me,
No, but the patient leaves with moderate TR, and it would not be happy, right?
No.
they're not going to leave the OR with moderate
But
TR.
let me say it again. The bar for that patient, that patient going to the, that's the funny part. You watch this dialogue, I love these kind of meetings. Samir tells me we can't reproduce mitral valve repair, therefore we'll do clips and get inferior results because everyone can learn how to do a clip. I think I can learn how to do one in like a week now, I'm pretty sure. So therefore, everyone should get a clip. Then the same panel will ask me, would you leave a room with moderate? By the way, would I leave a room with moderate TR? I'm going to ask the investigators, how can one of the endpoints of the trial consider moderate MR after a clip a success, which they do in their trial? Go to gov.org and you'll read it.
No, but that's the same
So
thing. I
there's
think
my whole point.
we cannot call it a
Because
success.
Michael's been wanting to say something for a long
No,
time.
but I just want to say one thing.
Say something.
I just want to address
Turn his microphone off.
I just want to say one thing, and that is, you've got 15 seconds. Good, we left you 15 seconds. You'll soon be 10. Because remember something about your TR and your MR. There is almost, like I said, if you go to the Mayo Clinic tomorrow, read their paper. If you have moderate TR and you're having a mitral operation, the TR is left alone. That's the surgeons. They're in the room. They don't do moderate TR. They think it will be stable or resolved. That's 2025. So there is no agreement that moderate TR has an impact on your life. Not even when you're having surgery, and there's no guideline to treat it. So would I be happy? No. In the OR, I would always go back and address that because I'm there and I'm not taking any risk with the patient. The patient's already taken all the risk, so I'm going to fix it.
Right.
In the MR world, never,
Never.
ever would I accept moderate MR because of the volume and the relationship to reoperations, and these patients generally have longer survivals. So yes, we do have to think a little bit differently about MR and TR. They're not all the same.
Okay, Michael.
Three things. The discussion about transcatheter replacement versus repair, we shouldn't make the mistakes of the past. We've learned over and over and over again in surgery that repair is far better than replacement. And for all the reasons you just outlined, Samir, we shouldn't be just saying, okay, well, let's just toss an Evoque in, because it has too many negative complications on the RV and future function. Second thing is, what this trial shows is a focus on TR. We're missing the boat. The trial, by reducing the amount of TR, it made no difference in mortality, it made no difference in heart failure hospitalizations. The TR, is it the chicken or the egg? It's actually, in all these cases, it's secondary, and the problem is that there's a list this long of things that are causing the TR. We're not actually targeting the problem. We're just targeting the side effect of the problem. Even in the CTSM TR trial, we showed that we reduced the TR, but didn't make any difference in quality of life, didn't make any difference in survival out to 2 years. And the last thing is around both this trial, Triluminate, and the early TAVR trial. It just shows us, because these trials were cooked from the moment that they came out. And, we are eager and excited to participate and get into these things, but, it takes a lot of time and effort and really shrewd trialists to look at these details in advance because if we would have spent the time in advance looking at the design, we would have realized that it was cooked from the get-go with these biased outcomes.
Can I ask you? We knew right away. I mean, when Everest came out, this was 10 years ago or more. It was cooked from the very beginning with the fact that that moderate MR is a success. So
2 minutes of blood was the same as mortality.
Good
job.
So, time out. But Michael, I have a question for you. Do you think that this is, I'm going to ask you do you think it's because these are industry versus Canadian government trials?
The tariffed Canadian government trials?
The tariff government trials?
Yeah, 100%.
No, but just now, if you don't worry about the take-home message, that if you have patients I take out my trial critique lab, but I see a lot of patients with TR, and if you reduce the TR, and if you have an excellent result with clip, let's say you have mild or trivial TR, that happens. So if patients do feel better, and patients don't come to the hospital. So I think that there is a clear, I understand that you have never seen that response in the trials because we have not been able to, but in just so you know, in the TRISCEND trial, we did see decreased hospitalization. So
that's actually true.
So there is an evidence that treating the TR, even though it's secondary, it helps. Just like in the mitral valve, Surgery doesn't work because secondary mitral regurgitation never decreased mortality, but in COAPT it did decrease mortality because the risk is not there.
But you're making the argument, about your experience versus two larger randomized trials. TRISCEND trial was much smaller than either the Triluminate or the CTS and TR trial. And you're saying that the
CTS and TR are different, right? Because there is
but two different spheres, randomized trials showed significant reduction in TR, but no difference in hard outcomes.
But this significant is
The
difficult
6-minute
because
walk test was exactly the same.
because I don't think that this reduced the TR too much with the clip. But when
But it was core lab read. The data
core lab saw the TR.
reported, everyone saw. You're telling me that the lied or
No, they didn't lie.
most important
There was
trial
still a lot of TR
All
left.
right, listen, most important trial of all is the Notion trial, and we only got 22 minutes, so go ahead. Seriously, we're going to get to the Notion trial.
I'm gonna say one last thing.
Last word.
Guys, there's the last word. Remember something, in MitraClip, everyone died in, COAPT, everyone died in 5 years. Almost all, half, two-thirds?
And it's like a 60-70% mortality.
That's right, we still don't know fundamentally what we're treating. We're palliating people, it's palliation. We're not curing people with structural valve, mitral or tricuspid valve disease yet for heart failure or ventricular geometry. We're not curing them, we're palliating them. It's like cancer therapy, we're not curing them. Like you can cure a patient with AS, you can cure a patient with
we don't know
degenerative MR.
except for
But here's the irony of this meeting. I have to say this one to Joe. Here's the irony of this meeting. We're talking about like TriClips and Evokes and this and that. Each one costs, the device itself costs $40,000. The hospitalizations,
it's more than that. It's
47,000, sorry. Then the hospitalization, so we're spending about $140,000 on 80-year-old re-ops in the U.S., and then we have Magni telling us that we need $8,000 to cure a child with rheumatic valve disease. We have a lot more discussions to do at meetings like this.
Thank you, David.
Maybe we better end on that. I had a comment, but I can't follow that.
You can follow up, Dr. Adams.
David, you should,
It's Notion 2
come on
coming,
up?
David.
Let's hear about Notion.
No, sir. So, by the way, we are not curing anything because I think only infectious disease sometimes can be cured. But I think the AS is not cured, you give another disease by doing this thing.
That's not quite true, actually.
And even the mitral valve prolapse, you cannot cure. Almost.
I was waiting for Michael to say that a Ross cures it, but he's not going.
All right, let's go.
I'm going, as soon as I show.
So, first of all, I want to say that this is not the trial that I was involved in, so I very clearly mentioned Ole Becker to say that he presented this trial. He's not here today, so that's why I'm presenting just the data. So we'll discuss the data. So this is a trial, a randomized trial. So the question was that we have so many randomized controlled trials for the low-risk patients, why another one? So this was a reasonable question to say, because most of the trials included patients more than 70 years of age, and they excluded the bicuspid aortic valve. So this is the reason why these 4 trials were already done, but this is a trial that made sense to do. Now, the design of the trial, in my opinion, is good. I don't know about the sample size, but the design of the trial is good to say that you take less than 75 years of age of patients and then one-to-one randomization, but stratify them by gender, coronary revascularization need, and bicuspid or tricuspid valve. So if you really do the sample size calculation, which they have, it would be a 1,500 patient trial to show the difference. But initially, they at least tried with a smaller sample size, as you will see. But it is stratified by gender, revascularization, and bicuspid and tricuspid. So the trial was 370 patients, TAVR 187, SAVR 183, and patient less than 70, if you want to see, they are 81 and 77, and as you will see, bicuspid valve is about 25 and 25. And here you can see that if you look at all the different ages, they are equally represented, as you would think, and the bicuspid valve is more common with the younger patients. Again, the primary endpoint, and we can discuss this, to say that it is death, stroke, or rehospitalization, and rehospitalization related to, so remember in the partner trial, the rehospitalization is in the VARC criteria to say valve-related rehospitalization. Here is procedure, valve, or heart failure related. So either of the three related hospitalization. So surgery-related hospitalization are counted. And then secondary endpoints are, as you see there, death, individual endpoints, major bleeding, aortic valve performance, and the functional capacity. That is a randomized trial. So if you see the randomized trial, the patients are equally distributed. STS score, bicuspid aortic valve, as I said, is in a small number of patients, 29 and 26. And the STS score is 1. So this can be operated at a very low risk. Primary outcome is here, death, stroke, and rehospitalization at 12 months. And as you can see, it is identical. It was similar. Hazard ratios, as you see, they crosses the unity line. P-value is 0.4. Follow-up is good. And death and disabling stroke. Interesting enough, I think in this trial, the stroke was a little bit higher. Again, statistically not different, but the stroke with the TAVR was a little bit higher compared to SAVR. And then you will know that this is because of the bicuspid valves that you will see. So this is a little different than what we saw in all the other trials. And when we
But that's not a little bit. 2.5 is, that's partner 1B. That's like 2007, man.
No, I know that this TAVR,
I wouldn't say a little bit, it's like 3 times larger than higher.
statistically, because of 25 patients. So
Yeah, but young patients in surgery don't have really high stroke rates.
what's that?
Younger patients in surgery don't have that high stroke rates.
This is what we are going to see. I agree with you, because this is, again, you see bicuspid, 15% of the patients had an emboli protection device, so it was not, in my opinion, state-of-the-art way of doing TAVR either. So this is what they showed. And then if you look at this, so death, stroke, and rehospitalization, 8.6, 5.2. Death and disabling stroke is 4.9. So this is a large number.
This is 1 year, right? Primary endpoint, 1 year.
1 year, yes, 1 year. Death and any stroke is 2.5, 1.3.
This is going to be so ugly at 5 years.
And as you can see, the stroke, so all the patients with stroke died. It looks that way, because if you see the 4.9 stroke and death is 4.9, disabling 2.5, 1.3, and 2.4, like this. So this is and heart failure related hospitalization or valve related or procedure related, higher in surgery compared to TAVR.
Do you remember if this was 100% core valve or mainly core valve?
No, it is 30% balloon expandable and 70%.
Yeah,
core valve,
I thought 75, but it's 70%.
Yeah, 70% is core valve. So, and here, the life-threatening or major bleed is more with surgery. There is no difference in kidney failure. A pacemaker is vastly different. As you see, 16.3, 8.3. AFib is 2.9, 27.5. And paravalvular leak moderate or greater is 5.6. So again, very, very, not very good results.
Yeah, that's by BAV stuff.
This is all BAV related, right? And severe patient prosthesis mismatch in surgery was 15%, which is not unheard of, so that is reasonable. And the aortic reintervention was 2.6 versus 1.2. But again, remember, 1% difference is one patient difference. So here the NYHA class, again, earlier on, it was slightly, if whatever you see there. And the KCCQ initially was 1 month was better for TAVR and then was equal for surgery. And this is the difference, that if you look at the primary endpoint by tricuspid or bicuspid, it flips, doesn't flip in the sense that you see the surgery 5.9, 7.8, then comes down to 10 and 0.
Yeah, but honestly, a surgery at 30 day of 6% primary endpoint of tricuspid valve, I'm sorry, I find that not very good.
No, it's excellent, because it includes the 4% are rehospitalization for primary endpoint included, like procedure, maybe they had effusion or they may be had AFib. So this is not super uncommon. And so 4%, if you subtract it, is about 2%, which is exactly the 2% for TAVR.
Yeah.
No, that's fine.
So I think it is
That's
not,
why I'm not a huge fan of rehospitalization for this primary endpoints.
but as you know, that the CTSN group is now blanking 1 month out.
That's exactly right.
For
Harry
the-
Marshall did that, and we've been pushing for that on the surgical side, where like just blank the first 30 days and then make it even. That to me makes.
That's what they are doing.
Also blanking the TAVR at 30 days is fine too.
Oh, I agree with you. So this is where, so 30-day blanking is done with newer trials. So if you do that, maybe it will be very, very similar for both the trials. And then there is, after 6 months, there is some more rehospitalization. So again, it's not very clear to me that what exactly happened at 6 months in TAVR, but exactly at 6 months, there were some rehospitalizations.
So what do you think about this TAVR 10.3%? What's your take on that? That's not yours, right? You're not seeing that at 10.3 at Cleveland Clinic.
No, but again, we are not doing these patients. So this is a important thing to keep in mind, that these are the patients that are bicuspid aortic valve. Again, remember the 25 people.
Yeah, it's very small.
Very, very small. So this 10% is 2 patients.
Yeah, but those are just credible results. I mean, they're going to look really, really, really bad at
It's
5 years.
25 patients, Joe.
25 patients, so there are 2 patients who have
Sometimes
something.
sometimes you only need 5 patients to figure out something's going on.
No. No, but it is not true that, I agree that small sample size, so that's why, but the p-value was still significant with even the small numbers when you go to 1.
It's real. Yeah. Sometimes I always say, Ram Tula, I love that guy. Some of you guys are old enough to have known him when he was active in the valve world. But he was a cardiologist, and he said, and he was a very tough guy, really smart guy. And he said, I don't really need a randomized trial to decide what I want to eat for lunch. I really don't need to see any more data to know what I want if I have a bicuspid valve, but you keep going and tell me how small.
No, but they did a randomized trial to say, the guy who published the highest number of papers in PubMed did a randomized trial to say that if you eat pistachio before you eat your lunch, your glycemic index is better. So you do have randomized trials for what you eat for lunch. He is the highest publishing author in the PubMed, 2,000 papers, and he just published. I just searched that what is he publishing. So he published eating 30 grams of pistachio before you eat your...
How many pistachios is that?
So it's about 15 to 20 kernels.
But you know what?
So this is what I was surprised. It is published in the Journal of Nutrition or something.
Before you eat, or?
30 minutes, before you eat your lunch, you eat those things, actually in South Asian population.
Yeah, I mean,
Sure.
But Joe, one thing but Samir, one thing that we don't need more patients for is to look at the red line of surgery. That's perfect. So again, the bar isn't non-inferior, you spent 1 less day in the hospital, you traveled 2 days earlier. It's, look at that line at 12 months. It's just a flat line. That's a pretty good, that's an early cure. And until you can match that line, I'm not drinking any Kool-Aid about, you don't need to have a sternotomy, oh my God. Come on, we got to get back to like curing valve disease and not talking about how less invasive it is.
So anyway, so this is, and again, as you saw, we took out the, the hospitalizations is 2% versus 0, so 2 and 2. So it is, at least looks good on the tricuspid side also.
It's like the partner 5-year trial that I was on the stage with when that was presented, and the win ratio was 1, and I will tell you that in the presentation, Joe, I'm surprised you didn't jump up then. You should have been on the stage. You would have used one of those little words. He says, and so we find the win ratio, the TAVR 1 at 5 years in the low-risk partners versus the surgery arm, one basically there was more early hospitalization and surgery and more death in TAVR. Huh, really? So I either get to, I have to have more hospitalizations, but I die less frequently. Okay.
No, this was for the evaluate trial. It also, there was a difference, but in the partner, actually, it was a little bit the other way. And here, they try to do, I don't know, it's such a small sample size, but this is another thing to say that, if all the different elements, they separated, and all the elements, as you see on the bicuspid look on the other side of the unity, they are, of course, crossing the unity line at individual levels. So why is this unique? Is because, as I said, that it included a young patient and did not exclude the bicuspid valve. And this is the first randomized trial of truly young patients, with 35% of the patients with bicuspid valve. There are equipoise with the tricuspid, but the bicuspid were less favorable.
Yeah, so it's clearly underpowered. The main limitation of but then with this result, do we need other TAVR versus SAVR trial in bicuspid valve? Because we have at least 2 major trials in line. And if yes, what would be the design?
Look, there are already trials that have been submitted to the NIH.
Yeah,
right?
Navigate and Believers.
Vino is one of the...
Raj and I have sent a PCORI grant that's in his second reviews. We'll find out in the next month or so who knows what will happen.
That's Believers?
That's been submitted.
And what's the trial that you submitted?
So there's 2 trials. One is a worldwide trial that CTSN is participating in, that has been submitted to the NIH. There's a separate trial that's been submitted to PCORI. For those who don't know what PCORI is, it's a branch of the government, of the U.S. government, that allows research outside of the NIH. So it's called PCORI grants, patient-centered, blah, 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 outcomes, something.
Research Institute.
Research Institute. So there have been 2 trials with the same principle, randomized surgery, transcatheter bicuspid trials. And so that has been formulated, and they're circulating through the U.S. government, but we don't know where the U.S. government stands with the NIH right now, honestly. So it'll be interesting to see where that
But
turns
the
out.
endpoints, you may want to, I don't know if it is possible to
They're
discuss.
similar-
So they're similar but not equal.
but they're
And
similar.
one is superiority and one is non-inferiority.
Right, but the point of it is that for me, the big part should be hospitalization. I think that's bullshit, that we have to include someone who came in because they got a little pleural effusion, we tap the pleural effusion, they go home the same day or they go home the next day. That does not equal death. And to me, I really believe that blinding or blanking for the first 30 days is not extra for cardiac surgery. It's the reality of how important a stroke is, how important a rehospitalization is, and how important death is.
Totally
You can't
agree.
put them all in the same category. For me,
Stroke and
that 30
death are
days-
okay.
That 30 days makes sense to me.
It's all
If you
part
do
of the
that, then I'm
operation.
okay with the trials.
No, and I think that
Ismail,
5 years.
Ismail,
5 and, no, it's 10-year follow-up, 10-year. 2 years. 2 years.
2 years.
but I think still think that it is not
2 years with a
right.
5-year, yeah.
Nothing will happen because they both will look very similar. If I agree, and see the other challenge is that by the time the 5-year data are published, the new generation of valves will come. So then people will say that, listen, this data, don't worry about this 5-year data, now you're a new valve. So there is a...
And the funding agencies don't fund for 10 years.
You may not like it.
This is the problem. They don't-
TAVRs and bicuspids are being done. And so you can't...
conducting a trial, let's get the endpoint to somewhere where it actually matters to these patients because they're young. And 2-year outcome, we may as well not do the trial, like Mike was saying earlier. That's just, it's just, the conclusion is pretty foregone at this point.
But nobody will fund a 5-year endpoint
then
trial.
we
So
should
that,
not do that.
industry refused to do the trial.
Well, I'd rather not have an RCT that says that it's equivalent because we have 2-year data and 2 trials that show the same thing, and then the guidelines change to a class 1 indication, you can do TAVR and bicuspids. I'd rather leave it as a question mark than having a poorly performed RCT that then gives false results with the promise of following the patients up to 10 years. And by 2 years, the guidelines change.
So Ismo, just remember this. The FDA has already approved bicuspid. It's already approved for TAVR.
No, but it is a question mark still in the mind of people, you're right.
Yeah, but it doesn't matter whether it's approved, and it's from a guideline standpoint, okay? Right now, the guidelines are pretty tight on bicuspids. They're probably going to get tighter, and I agree
How are
with...
they tied, Joe, on guidelines?
I agree with Vino. I have information you don't. And the...
What's said in here in Egypt, you can say it. It's okay to say it.
But I do agree with Vino that no one's going to fund a 5-year trial. My problem with this trial, for example, these two trials, is that the exclusion, my bet is just going to, I'll bet a really nice bottle of wine on it to anybody in this table, that the exclusions will be double the inclusions on this trial.
Yes, I agree. I'm not going to bet you.
But again, of course they will, just like in MitraClip. I'm sure that Samir is going to look at 20 P2s to decide which one can get perfect results, and then we'll randomize it. But it's the second it goes out, it's all comers. It won't make any difference, just like this trial. And pacemakers have a penalty. They have a survival penalty. It'll be 10 or 15%. For the life of me, I don't understand how cardiologists, if I had a 10 or 15% with pacemakers and mitral or tricuspid or aortic surgery, no one would send me a patient.
Yeah, but see,
you're right.
in
this world, no one cares.
The bicuspid, if you look at Lars Sonnegaard's editorial, pacemakers and BAV for TAVI is probably somewhere in the 12% to 12%, 13% range.
Whatever.
Right.
And that's all
And
comers.
you would pay the price, yeah.
And it's even higher in Evolut. And so, but here's the problem. You don't really, it's like Ismail just said, you don't really see that mortality until about 2 or 3 or 4 years.
That's my point.
In believers, we changed the design following comments from the reviewers, the first submission. So now it's last follow-up when the last recruited patient will have reached 2-year follow-up. So we estimated that's going to be a median follow-up of close to 4 years in our patient, which is, I think, better. It's not 5, but still, I think we're moving the...
You know the problem with research, though? Just want to say, too bad Bina left. Guys, we got invited to the bicuspid trial. Got a nice letter from the CTS network. You're in the network.
I know.
We want you involved. Your involvement will be critical to the success of this trial. We wrote back a simple email. Can you send us the inclusion and exclusion criteria? Oh, well, we're still working on. How do you agree to be involved in a trial that you cannot even look at the inclusion and exclusion? No. And my point is, this is where we've gone wrong. What happened to equipoise? Like, I look at the inclusion and exclusion, and I believe
this is
we can
actually
do
a
this or not.
gigantic. This is a gigantic point. And I have to be honest with you, I have made a U-turn here a little bit. I used to think that the prospective randomized trial was the best thing there was. But because of exactly what you're talking about regarding endpoint discussions and exclusion, gigantic deltas, I actually think a gigantic data set, of 50,000 patients that's very well prospectively propensity analysis is actually a better piece of data.
But Joe, that's exactly the point, but you just contradicted what you said 2 minutes earlier. You said, I agree with Vino, the FDA would not approve a 5-year trial, so
I
let's do a 2-year trial.
didn't say I agree with that. I'm just saying I agree with Vino that that's a political reality.
Oh, the FDA,
But you shouldn't do it, as Ismail says, we should not do.
We're talking like the FDA is a poor child. Why don't we go talk to the FDA and say, it's either we do 5-year trials or we just forget about the whole thing as a surgical community instead of running fake trials.
Surgery always falls to
where the
cardiology.
outcome
Always.
is completely
Always.
clear. And we know that at the end, if we don't stand
Yeah,
for
you
the
might be able to do that.
patients, who's gonna stand for the
Pecoria NIH is a little tight, a little bit. They might listen to that.
Let me ask a provocative question. To take David's point and go one step further, what's the point of doing all these trials? If you look at the evidence for TAVI and the evidence for MitraClip, right, and you look at what's happening in the trends in the U.S. for TAVI and MitraClip, and you try and align them, they don't align at all.
No.
TAVI and MitraClip is going buck wild on patients that were never even eligible for any of these studies,
Never studied.
regardless of it. So my impression is that the studies are only to gain entry through regulatory, and then everyone just does whatever they want.
So this is the reason why the industry does not want to sponsor the trial, because the industry says that there's no point of sponsoring the trial because people are already using the device. So they say that why are we going to do the trial? Right now, the FDA, just for your point, the FDA approved TriClip and Evoke, both, with a very little data, right? The data, as you saw, relatively small amount of data, and now they're saying that you continue to do the trial for 5 years. I'm part of the NCD, and they say no volume requirement. So NCD says no volume requirement. If you are doing your first clip, you can still do your first clip, no worries. So this is, or do 2 clips a year. So industry likes this kind of things to say that, okay, let us get it approved, and then
Yeah,
we
well,
will-
I was actually on that committee, yeah, so it's full.
we are all,
I was on the committee, and you were on the committee too. And, no, and we wrote, the 4 societies wrote a much stronger,
But they
you know,
rejected it.
institutional and operator requirement, and then the CMS just said, screw you, really. It was really amazing.
They just did, and we are going to write a paper.
So
but my
somehow
point is
CMS is decoupled from the professional
because it
societies.
is from the industry, right? The CMS told the industry that you do the trial, you are responsible, you deal with it, and we don't want to have any regulation over who we pay. So your point is right, that this is going to be a trial that is going to help the industry rather than in any way hurt them.
It's not about helping or hurting the industry.
But a wrong message. Wrong message,
I
yeah.
think for the patient, and I don't think that the trials are designed to answer any questions that are patient-related. 2-year outcomes in a 60-year-old tells me what's going to happen by the time they're 62. And that really is not, that
But see,
doesn't start to answer
but
any
the people
question.
designing the trial
Yeah.
are also, their lifespan is not 5 years. So you do 3 years of trial, and then 5 years you wait for result, so half of them will retire. So there is
The
a,
trial is.
so that's why nobody's
the
interested in
trial
doing
is
this kind
then
of.
for the patient.
I understand that, I'm just telling you that
We're
the
just
other side.
we're opening.
It's 5 o'clock.
We do terrible randomized trials. In pills, you take a blank, you don't know what it is, everybody gets randomized. They're fair trials. In this business, whichever device or widget you're trying to support, you will select the patient so carefully to make sure your widget works, and knowing the day it gets released, it's a wild, wild west. Anyone gets it, and that's all the forces that are trying to get these things approved care about.
Yeah,
That's
and
the
I think for
industry.
the young ones in the room, I was doing the Meet the Mentors today, and someone said, what do you think? I said, number one thing is you have to be not cynical, but very critical. You have to learn how to read papers and how to read the methodology. Forget the conclusion in the abstract, because it's meaningless in this day and age, particularly when it comes to the New England or the Lancet or one of the very high impact factor journals. The methodology is where all the money is, because that's where you see all the funny stuff that all these discussions here.
Yeah, print the appendix if you want to learn something.
Yeah, you need to.
Now they don't allow appendix either, so no, in my last paper review, they even rejected my appendix.
Thank you so much. This was the best session of the meeting, I think, at least the most passionate, let's say.